So as Karen said, it is great to absolutely be here this evening. I'm going to focus the presentation within my context, my experience, my understanding. While this is a public lecture for the University of Cumbria, the thoughts I'm giving might not necessarily represent the whole of the university, but they will represent my experience and my thinking. I guess one of the things I'd like to start by saying, other than I've probably never felt this nervous in quite a few years, which is unusual for me, but it's quite different doing a public lecture from the London campus when I'm actually in my office in Lancaster and not, sitting behind this red bus. It's quite different doing a presentation online because I'm quite used to reading the room, reading people's faces, seeing where people might be confused by something you say, and then adapting to that in a public lecture. So this is quite a different approach, but we'll give it a go and see where it goes. I'm going to talk this evening about the nursing workforce. I'm also going to talk about some other healthcare professions, but as a nurse, I'm going to base my topic this evening on nursing. So I'm going to tell you just a little bit about me so you get the understanding of the context. I want to talk to you a little bit about how nursing has changed over the years and actually some of the crisis issues we're now faced with and what we might need to do. I would also say at this point that a kind of lecture of this time and this size cannot deal with all the complexities that we face within the nursing challenges within the UK. There's huge battles ahead of us, huge struggles, huge challenges, which are absolutely going to need a different way of thinking and a whole systems approach. And I will unpack what I mean by that. But I'm going to give you a flavour and take you to some of the evidence and some of the research that actually helps inform that thinking. So a little bit about me. I left school at 17 and went straight into the NHS as a healthcare assistant. I did a mental health nursing training. It wasn't a degree in those days. I qualified as a mental health nurse and I worked in a hospital called Sunnyside, which always felt like a very peculiar name for a mental health institution in Scotland because there was nothing sunny about it in the northeast coast of Scotland. But I worked as a mental health nurse. I started off in a unit looking after patients with dementia, and then I very quickly found my home in substance misuse and working with people with real life problems where the response was using the addiction of alcohol or drugs to help them cope with life's challenges. I worked in the community for quite a long time as a community alcohol and drugs nurse. And then I went back to training and I became an adult nurse. And then from there, I worked, as Karen rightfully said, in many areas of adult nursing. Was a charge nurse in several units. I entered education then as a lecturer practitioner. I worked part-time in practice and part-time in a university. And I've worked in 6 universities within the UK throughout my career, moving full-time into higher education in 1997. I've never ever been a full-time university student. Every degree that I've done, I have 5 degrees. I've got degrees in politics, education, a couple, advanced practice and NHS administration. All of my degrees have been done part-time, so I've worked full-time and been a part-time student, and it's taken me a long journey to get the degrees that I have. But I wanted to do that because I knew very quickly in my academic and clinical career that education was for me. I had a real passion of teaching people how to care, how to interact, how to intervene with people, how to respond in an emergency. And from my clinical career and then moving into academia, I moved eventually back home to Scotland, where I went to Robert Gordon University and had a fantastic experience at Robert Gordon, a really thriving, high quality modern university in Aberdeen. And I very quickly after a year became the head of the Scottish Heads of Academic Nursing and Allied Health Professions, which then morphed into the Council of Deans Scotland. And then I became chair of the Council of Deans of Health UK, following a suite of very distinguished people who've previously been chair, some of whom I will mention this evening in this presentation. And that, if I analyse my career to date, has left, I think, in me a set of skills that are now usable within my higher education wider experience and in the types of discussions I have in the UK today around nursing and around workforce. The clinical practice experience across a wide range of disciplines never leaves you. While you might become outdated in some areas, the core fundamentals of care I have found as a nurse are there within most things I do and how I respond to individuals and to crisis. Nursing and higher education is me. That is my identity. I see myself as a nurse and a nursing academic and as an educationalist who has expertise in health policy at a very strategic level and dealing with policy, challenging policy and informing policy. And I'll talk a little bit about that. I think that leaves a set of transferable skills that are never lost in my view. And two key aspects to that is political astuteness and emotional intelligence, which I think are really important factors for dealing with some of the challenges that we have today. My national role as chair of the Council of Deans means that I am regularly interacting with regulators such as the Nursing and Midwifery Council and the Healthcare Professions Council, and regularly liaising and working in partnership on initiatives with the Royal College of Midwives or the Royal College of Nursing and various other arm's length bodies. One of the organisations I would say that I am most passionate about is the Queen's Nursing Institute and the actual focus on the importance of community nursing, the skills that are required for community nursing. And I've had the privilege in the last 5 years or so while I've been chair of the Council of Deans to build a closer relationship with the Queen's Nursing Institute and gain a deeper understanding of the importance of community nursing. And I am actually going to highlight the need for us to change in our thinking and delivery of higher education to become more community focused in order to address some of the challenges that will inevitably be there going forward. So I'm going to focus on nursing, but as I said earlier, there are similarities with other disciplines. It would be very difficult to talk about the nursing workforce in the UK without understanding a little bit about what nursing is, where it's come from, and actually, more importantly, what nursing isn't. And I think many people that I meet have lots of understandings about what nurses do. But when I talk to them, I find that they're quite historic or they're quite out of date or they're built on a memory from long ago or they're built on a perception of what people think nursing is. Several years ago, I think about 2013, I undertook a Commonwealth leadership programme. It was a leadership programme that consisted of 100 up-and-coming leaders from across the Commonwealth. It was quite difficult to get into. It involved an interview at the House of Lords by the sponsor, and I went on this programme in 2013, and it was also sponsored by the royal family. So there was a royal visiting the programme every day. It was a 10 days, quite intensive study period, followed by 7 days in South Africa, looking at leadership in South Africa, actually in Johannesburg. And I remember one of the royal family, and I'll be very discreet and not say who, I remember one member of the royal family saying to me, "I don't understand what you do. You tell me that you're a professor of nursing. How can you get professors of nursing? Surely nursing is a vocation. It's something you're called to do, and you just need to learn how to care." So I informed that member of the royal family that they were out of date, politely, as you do, with respect, and said that I'd be very happy to have a conversation about why that view of nursing is quite out of date, thinking I would never hear anything about it. A few weeks later, I was contacted by said member of royal family to say, "I've been thinking on what you said and I'd like to discuss it further." And that led to a series of conversations around the importance of evidence-based practice, graduateness for degrees and for nursing, and the complexity and the importance of care. But here we have Florence Nightingale, who's often seen as the founder of nursing. Florence was a statistician by background who as we all know, had great experience as a nurse during the Crimean War. She set up St Thomas's School in London for the nursing school, and she made great efforts to reform and inform what nursing was, and actually started the pioneering we often refer to in my discipline as the pioneer of nursing, and many of which things that Florence said and did still have resonance to nursing today. But nursing has changed over the years. Mary Seacole was a British Jamaican nurse and businesswoman who set up what was known as a British hotel behind the lines during the Crimean War. She was described as a woman of great candour, of secure, and she helped wounded servicemen in the battlefield, often with home remedies that she had previously used in Jamaica and West Africa. And she displayed huge compassion, huge skills of bravery while nursing soldiers in the Crimean War. Things that I think the nurses have to still do today: have compassion, have bravery in the care that they give. Nursing is a very unusual profession for people to come into, in the sense that it's inevitable you will work with people that will die. It's inevitable that you will work with people who are seriously sick, either physically or mentally. And people from a very young age or mature age have to learn the skills of how you cope with that on a volume and on a depth and on a regular occurrence, which is not usual compared to some other professions that we might see. And that takes great skill, great tenacity, and huge compassion and understanding, which has to be based on an evidence, in my view. A couple of other people I think who've helped transform nursing is this lady here, Professor Dame Jill MacLeod-Clark, who was identified as one of the 11th most influential nurses in the world. I had the pleasure of working with Jill for around 11 years and still work with her on some national agendas today. She did a huge amount of research, and she really pushed research over the last 20 to 30 years in the UK from a nursing perspective. She focused on long-term conditions, smoking cessation, health policy, and latterly she's really pushed forward evidence-based on nursing workforce and nursing careers. She led for the Nursing and Midwifery Council the revising of the standards for nursing that were published not that long ago. And lastly, Dr. Crystal Oldman from the Queen's Nursing Institute, and I noticed that Crystal is online with us this evening, but Crystal has an extensive career of working in higher education and working in practice, and has been the voice and pioneer for community nursing in the UK. There's much to learn about the importance of community nurses, district nurses, health visitors, and what they provide to a changing environment and society in the UK, and something there for us to reflect on for those of us that work in education, around perhaps the traditional approaches we have within our curricula that's very hospital based at times, obviously has placements and experience in the community. But as the balance of needs of care change in the society, I would argue the balance of our curriculum needs to change in order to educate those nurses for caring for the future society. So nursing has changed and been influenced by huge pioneers with great experience and great wealth. Men into nursing, of which I am clearly one, took a little bit longer, and George Dunn was the first recorded male nurse. And we then saw around 15 other male nurses enter the first register of nursing in the UK. And by the end of 1922, we started to see a growing and increased number of men coming into nursing. Usually, I have to say, in those days, they were trained and educated in the army, and actually that's how they came into the health caring profession. So nursing has changed over the years, and it's been influenced. And nursing has changed in my time over the years. Here's me at the delightful age of 21 when I qualified. Here's that handsome looking chap, and my dear friend Susie, who has since passed away sadly with a brain hemorrhage. But nursing has changed, as so have individuals. Nursing, of course, comes from the Latin word nutrix, which means to nourish. And that it kind of resonates with the traditional views of nursing, which were around nurturing, which were around care. But definitions of nursing have changed over the years, and definitions of nursing have helped influence and reflect perhaps what nursing is and what nursing isn't currently in the UK. Webster-Henderson is probably one of the first pioneers of defining nursing. She was actually born in 1897. She graduated in 1921, where she trained as a nurse in the army in the USA. And she was one of the first nurses who then completed a master's, which she undertook in New York. But she was a radical, and in 1988, I remember this, when she came to the UK and was interviewed by the Royal College of Nursing, by the General Secretary of the Royal College of Nursing, who at that time was a gentleman called Trevor Clay. And she, at that time, absolutely advocated that however nursing changes, the basics of nursing must continue. The basics, which she's translated in this definition, are a core fundamental rock, however nursing changes in whatever shape and whatever area. And actually, I would argue that actually her definition still holds a lot of resonance to care today. And actually, there would be wisdom for us to understand and unpack how we translate that definition into a modern and contemporary practice of nursing. The International Council of Nurses has further developed that nursing. You'll notice that in this quote, the first part of it is very similar to Webster-Henderson's quote on nursing. But the International Council of Nursing started to bring in the importance of advocacy, safe environment, research, shaping health policy, systems management, education as identifying key roles. And that tells us the sign of the times, that there was a beginning to change the influence and perceptions of what nursing might be. From my own perception, I want to make it very, very clear. Nursing is not around following instructions from other healthcare colleagues. It's not just about bathing patients and making them comfortable or making beds. It's not just about walking on a ward round or writing up notes and following a list of tasks that have been given to you. And it's not just about relying on others for instruction. I would have to say, when I first went into nursing and qualified as a nurse, some of those things would have accurately described what nursing was. But nursing now in 2023 is a hugely complex profession. It draws on a range of knowledge from a range of disciplines to look after clients who have much more complex healthcare needs. I certainly think from when I worked in a medical unit, the types of patients we now see in medical units are much sicker, have much more multi-related problems, multi-pathological, mental health problems as well, psychological challenges, and are much more severely ill than maybe we first saw because of the advancements in technology, medication, and importantly, care in community care at home. Nursing utilises an evidence base that is research informed and research designed to give innovations of prescribed care. And that research base for nursing has seen nursing grow in its research base since it came into higher education in the main in the mid-1990s, but there was quite a few programmes in the UK that were degree programmes before that. And we now see nurses undertake physical histories, assess patients and clients. We see them diagnose. We see them through time and further development prescribing as autonomous practitioners. We see them entering in certain fields of nursing into specialist psychosocial interventions such as cognitive behavioural therapy or solution-focused therapy or other approaches. Because the needs of healthcare have changed, the needs of the profession have changed. And some of that change has been because of the shape of the workforce, where it's been difficult to achieve recruitment in some areas, and we've grown the skills of nurses in other areas. I'm not going to go through this slide in any detail, but the key bit here for me is that actually you can see that nursing moved from the days of Florence to 1990s, where we saw a bigger move of nursing into higher education, and where we saw in 2004 the RCN, for example, voting that degree-only preparation was the only way to go, and by 2009 all nursing courses in the UK became degree level. So we're in 2023, it's still quite a young profession from a graduate perspective compared to other disciplines across the UK. But my own reflections are that nursing roles have continuously evolved. Nursing knowledge has continued to grow and needs to further expand. Nursing skills have expanded as things have changed and moved on. And nursing is ever changing, as is the evidence base. I think from the days that I entered nursing, there was no such role in the UK as a nurse practitioner or an advanced clinical practitioner. But now we see those roles in abundance. We see a huge increase in clinical nurse specialists, whether that be within any field of nursing, including mental health, where we see lots of specialist nurses. So nursing is an ever-changing profession which dynamically needs to change and grow. And it should be based on evidence. And I was thinking as I was preparing this around some of the evidence that really should be impacting on what we do as nurses and how we think about the workforce. And I was thinking about the work of Linda Aitken, who published in The Lancet in 2014, references there for you, with a whole range of colleagues. This was a study that went on for several years across 9 European countries, and actually found that an increase in a nurse's workload by 1 patient would increase the likelihood of an inpatient dying within 30 days of admission by 7%. This was done on surgical patients across 232 hospitals in Europe, and also did surveys of over 250,000 nurses and looked at their education background. But what this study also showed was that a 10% increase in bachelor degree prepared nurses was associated with a decrease in the likelihood of this mortality. So really what the study showed, and I would urge you to go and read it, it's a fascinating read, and it's one of many studies which was really designed in a time where the view was that actually many reports that were coming out, such as the Francis report, and the KEOP report, were identifying that cutting nursing numbers and nurses as part of the workforce was not a sensible thing to do and would have an impact on the culture of care and the culture of quality for patients. This study was one of the first of its kind that demonstrated that patients in hospitals in which 60% of nurses had bachelor degrees and nurses cared for an average of 6 patients, which is quite unlikely in our current climate in the UK, would have almost 30% lower mortality than patients in hospitals in which only 30% of nurses had bachelor degrees and nurses cared for an average of 8 patients. So in summary, the qualification of the nurse, the volume of nurses who are qualified to a graduate degree level, and the number of patients they looked like was evidence to have a demonstrable impact on mortality within these patient groups. And if I think about the journey of nursing and how it's changed within higher education, it is really interesting to see that in 1972, we had 1 professor of nursing in the UK, who was Margaret Scott Wright, who was at Edinburgh University. And here we are in 2023. And when I looked up the last database yesterday afternoon that the RCN do on a regular basis, we could see that we had 314 professors of nursing, all named by university, by region across Scotland, England, Wales and Northern Ireland. And I'm very pleased to say I'm one of those 245 in England, and very proud to be a professor of nursing and stand up and advocate for the voice of nursing in the UK. So nursing has become a huge profession in its own right, not just through volume, but through its academic credibility, its preparation of practitioners, its evidence-based to inform practice, and using research to change the shape of the workforce. And that's great. But where are we now in the UK? We've got a recruitment crisis in the UK. The UK government published a report in 2019 identifying a need for 50,000 more nurses by 224. I can tell you from my role as chair of the Council of Deans, I have no idea where that 50,000 target came from. I can absolutely tell you that the evidence in subsequent reports by the King's Fund, by the Health Foundation and by other external bodies have demonstrated a much bigger gap than 50,000 by 2024, some of which I'll take you to in a moment. We also have a reliance on overseas nurses to fill that gap within the UK. In a context, I have to say, of current tough overseas immigration policies. And there could be, and I won't go down this avenue today, but actually from a global perspective and looking at some of the World Health Organization's reports on the state of nursing, there are huge challenges with international migration of nurses from some countries into the UK, and that drain-brain perspective on other parts of the globe is something on a world global scale we are going to have to address going forward. If I look at the data of how many nurses are needed by 2030, I can see that that will continue to rely on a huge international influx of nurses to the UK. And while that's welcomed in many ways and is part of the society that we live in, there will be inevitably a negative impact on some of those countries. I was talking to a leader a few months ago now from Nigeria that was telling me they were having to close intensive care units because they could no longer staff them because staff had left Nigeria to transfer either to America, Australia or the UK, where they could get better salaries, better qualifications going forward. And that was leaving a terrible impact on the needs of patients and the care system in some of those other countries. We have a role to think through the ethics of some of those challenges of the policies that we have, as well as looking through some of the policies that we're trying to address in the UK. The COVID pandemic saw a huge popularity for nursing. We saw an increase of applications in 2021 for nursing programmes across the UK. We saw an increase for other professions as well. But here we are in 21-22, we saw a fall of 5.9%. And if I look at the latest data in the UCAS reports that came out in January, I can see a further fall expected for this September. The attractiveness of coming into a healthcare profession such as nursing is in decline. And we absolutely have to acknowledge that to see how a systems approach we can do to address that. Nursing also in the UK faces high attrition with a different pattern of attrition compared to other university programmes. Where I might expect to see attrition in year one of some programmes, I can guarantee from my role in the Council of Deans that if I was to look across many providers in the UK, I would see attrition in year one, year two and year three. And actually some of those reasons for attrition aren't always academic failure. There could be personal finances, there could be workload pressures, there could be poor clinical placement experiences. And it's interesting to see in the report that was published this week from Health Education England on their national survey, the amount of comments from students around poor practice placements and bullying in practice and lack of support in practice. All of those things impact the perception of the profession and the attractiveness of nursing as a career to go into going forward. The Million Plus group of universities published a report just last month in February around an analysis. It was a policy document around an analysis of data for some of the challenges that we could see going forward. And if you look at this summary of data, some of this was taken from Rox et al, who did some work for the Health Foundation, where they looked at projections for health and social care. You can see that the volume anticipated, and it is a projection, is 429,000 nurses would be required in NHS England, they've also done data for Scotland, by 2030-31. 429,000. It is mind-blowing. That would require 365,000 nurses to be recruited over the next 10 years, 160,000 student nurses entering England between now and 2031 on an average of 18,000 a year, and 1/3 of nurses still to be expected to be recruited from overseas, from a wider labour market. You know, this is a huge problem. And if I went to every university today and said, look, double your intakes, and every university managed to double their intakes of nurses for the next 3 to 5 years, it still wouldn't be enough to fill the gap. So we have to ask ourselves the questions, so what more can we do to address the workforce shortage in the UK? And I look at some of the conversations I have with my higher education colleagues who will rightfully tell me, and I would join them in this, that we have responded to government calls of diversifying our routes into nursing. Most universities, particularly in the modern universities, and it's interesting to note that about 73% of student nurses come from what we would call modern universities, as opposed to what we might call research-intensive universities. 73% are educated in modern universities. But we've diversified our routes. We have apprenticeships, we have 3-year degrees, we actually have postgraduate routes into nursing for those that might have a degree already. A very quick entry into the workforce to do a 2-year programme if you have another degree and go into nursing, a much quicker route. We've developed closer partnerships with the NHS. We've worked intensively with Health Education England and partners who've done a fantastic job in working with the higher education sector in looking at placement capacity and making sure that the NHS can cope with any increase of volume of students. And we've seen some small increases in simulation and the use of technologies, but not near to the extent which I know will be coming round the corner as part of one of the solutions to how we educate and help people develop their skills going forward. So we have some big problems, and big problems require big solutions. And it's up for us to be part of those discussions around what some of those solutions might be to the workforce crisis, or where we should be focusing some of our attention going forward. I said I'd had the pleasure of working with Professor Dame Jill MacLeod-Clark, which I have, and that pleasure has extended to working together with Jill with a number of arm's length bodies across the UK to help develop some key thinking about what we might need to do going forward for the workforce. I want to present to you 5 considerations of things that we need to do as we think about bigger solutions. And then I'd like to go on and talk about what that might mean from a higher education perspective. So some of the challenges we have because of the decrease of people within the NHS, the decrease of nurses within the NHS, and it is important to recall that as much as we are putting nurses into the NHS system, we are seeing nurses leave the NHS system. So the ability to retain people in the care environment and care roles has never been as challenged as it is now. There is some data available, it's not easy to find, around the number of people that might be leaving the NHS and in what times they might be leaving the NHS. And that is an alarming rate of nurses that we are seeing. So that leaves us with some big problems that we have to focus our energies and attention on, such as limited supervision, support, and traditional practice placements. They have an issue of capacity and capability, and that impacts on the student experience. And it's not unusual in higher education, as many colleagues in this call will know, in order to be really flexible and work with your NHS partners when a system closes because they've lost staff, or a new ward opens, or a community placement can no longer take people because they've lost the practice nurse, or they've lost so many of their advanced practitioners or district nurses, or actually that we work with those partners in community to look at different models about how they could take more students and not from a traditional basis of one-on-one. And all of those things need looked at from a supervisory perspective in order to meet the requirements of the registered profession. Second consideration is around increasing registered nurses and midwifery, all the staff shortages that we see, the recruitment challenges that we have in HEIs, the recruitment challenges that we have in NHS, and all of that has an impact on the requirements for growing in our student numbers. That combined impact of shortages is a huge issue, which also needs to be solved within the crisis going forward. And the lacks of flexible, system-wide and cross-sector educational and career pathways really don't have a huge impact on the existing workforce. By that, I mean that actually we need to see developing abilities for people to come into education and practice and move seamlessly through that. One of the really interesting things of working with Imperial College London to establish the Cumbria School of Medicine is the learning from the medical approach to some of these systems. It's quite an unusual model we have when I reflect on it around nursing midwifery, where people leave practice to come into higher education, as I did. And I realised very quickly that I was in danger of becoming de-skilled in my clinical practice quite quickly. And in one of my universities that I was at for 11 years, I very quickly moved back to a position where I could spend one day a fortnight in a GP surgery, in practice, looking after patients with drug and alcohol problems that helped inform my interactions with students and my skills as an educationalist going forward. I think we've lost something in the models that we've evolved to in nurse education, where people leave practice and come into higher education and have lost the confidence and ability to work seamlessly across contemporary patient care, understanding the challenges the NHS is facing and being able to work in a more effective way with our students. And that is something I absolutely, as I get older in my career, feel that we fundamentally have to change the model of what we're doing in order to have an impact going forward. The absence of a cohesive and equitable career development CPD framework is a really another huge issue. If I think back onto my career, and it is quite startling when I think about it, I did my mental health nursing, I did what was called an English National Board study programme in substance misuse. I did one in teaching and learning. I then became an adult nurse. Oh, what would I do now? Oh, actually, I did another English Nursing Board qualification in intensive care and everything else. There was nowhere that told me what the parameters of a development and sustainable career might be in the NHS, or how do you get into higher education. None of that information was available. We didn't seamlessly have career pathways. We still don't have career pathways. If I think about how a student could move from student through different systems to becoming a professor, it does not exist. If I look to how a student could seamlessly move through care within a mental health environment to become a specialist nurse in drug and alcohol careers, it doesn't currently exist. Many of our opportunities are on the needs of the workforce, helping and encouraging people or responding to what people think they might do next. We need to become smarter, cleverer and clearer about pathways through people's whole life learning in order to make them stay in nursing and make nursing become a career that's desired by people today in our society. And I think there are multifactorial barriers to transforming the way students learn and practice. And we need to be thinking about alternative approaches to how people, individuals, can achieve practice outcomes without having a huge demand on the clinical practice needs that are ever changing. Now, I just want to be really clear on that. I am not advocating today that we don't need clinical practice to educate our nurses of the future. We absolutely do. But there are many skills that someone can learn through simulation, through technologies, through different educational approaches. And we need to make sure that we're not stuck in a traditional model of coming into university, going into practice, coming into university, going into practice. We have a skills lab. Every university's got a skills lab, and we teach this clinical skill, this one and this one. We need to think more radically about how we use technology in an ever-changing technological society to educate our practitioners going forward. And that has to be a radical thought. And I'll finally finish this part of this lecture on another challenge for higher education. In 2019, the organisation that I chair, the Council of Deans of Health, did a survey of its members. At that time, we had 85 universities. We now have, in 3 years later, 2000, you can see I'm trying to do the maths in my head. 4 years later, in 2023, we now have 102 universities. So we went from 85 to 102 universities who became members of the Council of Deans of Health. To become a member, you have to provide nursing, midwifery, or allied health professional education or research. So either we had a lot of members, a lot of universities who were not members, and there was a few, I could probably have named them on one hand, or we've seen a growth in the number of universities who are coming into the market, but we're not seeing that growth reflected in the number of student outputs that we're seeing at the end. However, we did a survey in 2019, and what we found from our members, and this is published on the Council of Deans website, you can access it free of charge. What we found was that universities were now telling us they were struggling to recruit from practice into higher education, and that was multifactorial reasons. It was taking much longer to fill some posts, and we found that many posts were still not filled after a year. And those posts were mainly at lecturer and senior lecturer grade. That's really important to understand. We could analyse from that people were losing the attractiveness of the profession. We saw practical problems where salaries in the NHS were now higher than starting salaries in universities. So why would you come from one place to another if your salary is not going to be met or not going to be the same? We saw issues that our members were telling us, but my university now says you have to have a PhD before you can come into university. Or we saw barriers that seemed to be self-made that said, well, you have to have a teaching qualification or you must do a PhD when you come in. All of those things are important in their own right, and they're important for universities to independently manage their businesses. But collectively, across the system, we saw that there was a reluctance for people to come into higher education, either through practical issues or because they saw that actually higher education was maybe not once the attractive opportunity that they thought it might be. So I posed the question at the beginning, growing the nursing and healthcare workforce across the UK, an uphill battle or a self-made struggle? And I think it absolutely needs us in the UK to have a total new paradigm, a new model for how we educate and attract people into nursing and our other healthcare professions. And it's time to move on from traditional views and to think more radically about what we do in order to meet some of those growing demands going forward. But what would a new paradigm look like? And I'm not advocating tonight that I'm actually going to prescribe to you what that new paradigm is. That's too contrite from my perspective, because it needs a whole systems approach. It needs some radical thinking by partners in practice, whether that be hospital or community setting, by arm's length bodies, and by different government departments to think about what we need to do to realistically address the shortages that are inevitably going to affect the care that you and I might be receiving one day from the NHS. I actually think some of those solutions lie in some of the things I'll say to you today, but this needs much more unpacking. And you may disagree and you may have your own thoughts. It'd be great to hear some of that when we get into questions and answers. But we need an educator career framework. I'm going to start with education because I'm a higher education individual. We need an education framework that delivers a cohesive, fit for purpose and flexible cross-sector career pathway for nurses and midwives. Every registrant in the UK has a responsibility and a role to play, in my view, around looking at theory and practice and how we support our students. That may work in a more flexible, seamless approach across practice and education, or it may work within a pathway that allows people to support learning in practice in a different way. I've been thinking over the last few months, and please don't faint or feel shock horror when I say this, but I've been thinking over the last few months about when I was a student and the value that a clinical nurse teacher, someone who came out onto the wards to work alongside me as a student, had on my impact as a training nursee. I spoke to another colleague a few years ago who implemented the role of academic nursing education translators. That's probably not the right title, but it was about how do you work with students to make sure they understand the current research and how that transforms into practice today. Almost like a clinical tutor role, as many of us in this audience will have had, but actually looks to support students in a different way in practice. We need some career frameworks, I believe, to do that. And we need an infrastructure that will make sure there's an equitable approach to that across the system in both higher education, health and social care. And it needs a radical new approach to supporting students in the development of their practice skills. You know, there's nothing magical, and I don't mean this in any insulting way to our regulator friends who I have the highest of respect for, but there is nothing magical in nursing in the UK about 2,300 hours of practice and 2,300 hours of theory. We are in the world one of the highest practice requirements globally. Countries and nurses that are trained in other countries do much less practice engagement than we do in the UK. So what makes 2,300 hours fit for practice? It was a European requirement and we responded to it. Irrespective of my views on Europe, we are not in Europe now. So what do we need to do to think more radically about how we help people develop skills which might not have the burden on practice and might use practice placements more effectively? Nursing students enjoy practice. I know that because they tell me. They enjoy patient care in the main, and they enjoy learning new skills. But we have to equip our students, not just for the here and now, but care for the future. And care for the future is transforming. I had the great pleasure of being a keynote speaker in Finland, in Helsinki, just before, a few months before COVID broke out, about 6 months before. One of my takeaway thoughts around care in Finland was around the use of artificial intelligence and the use of robots to care for patients in a country over a huge geographical area, much of which was barren, and how they were using robots to be companions to the elderly, to remind them to take tablets, to be a person that could contact emergency services or a healthcare practitioner should they be becoming ill. And they were educating their students in technology in order to do that. That's a radical different approach from what we might find in the UK. I've had the honour of being an honorary professor at Johns Hopkins University for the last 6 years, and I've made several trips to Johns Hopkins in Baltimore to work with postgraduate nursing students and faculty staff within there. And their approach to clinical skills would bear no resemblance to what I see in most UK universities, the use of technology and the intervention of case scenario based interventions and the analysis that was done with those students is probably next to nothing that I've seen when I've worked across different parts of the UK. And I say that from someone who's worked in 6 universities, and one in which we absolutely transformed curricula, where we reversed against a lot of tide of unhappiness, where we put all of our first year students into community settings for the whole year. For the first year, every placement they did was in community. And I was told that actually you can't do that. They can only learn skills within a hospital practice setting. And I started to wobble and get a bit nervous about it, but was determined to change the balance of learning experience for students. And actually found that what came back at the end of that first year was students who had a wider understanding of global and population health, a wider understanding of team working, from a much bigger background, a huge understanding of how to work, communicate and interact with families and communities. Yet I don't think I've seen that approach as widespread across the UK as maybe we did back in that period. And finally, just coming to the end, you'll be maybe pleased to hear, I'm sure you don't want me going on too much longer because I think there's probably lots of questions and maybe some disagreement, which is fine. We need to think about considerations for future curricula. I absolutely believe first and foremost, our curriculum in the UK needs a stronger community focus for whichever field of nursing that may be in, for some of the reasons that I've just said. And we need to think out of the box around how we build in issues of artificial intelligence in periods and times with what's going on in our local geographical situation as well as nationally. We need to be thinking about the impact of sustainability on our society, environmental issues, and the impact that that might have on care going forward, and the skills and knowledge that we need to teach our practitioners. We spend a huge amount of time and money educating our nurses once they're qualified to become advanced clinical practice and skills. And while I totally agree that some of that is absolutely important to be done at that period, it does make me think about what skills should we be teaching now as a journey to advanced clinical practice in whatever field, and how can we do that within our current educational structures? We need to become much more radical in using technology to inform our curricula and our students' learning. And we will need to see a further expansion of skills. I said at the beginning, roles such as a nurse practitioner or roles of nurses being non-medical prescribers didn't exist when I was a student. And there'll be many much more changes to our current students as healthcare changes going forward. And we need to be thinking about those skills. I often think, and one of my brothers has substantial mental health problems, and I often think in relation to that, why does there need to be so many different practitioners going into the home to provide different care for our patients? And actually there may be a need going forward as health and social care becomes more entwined, that actually it's not around different roles going in, but it's about a different skill set for the roles that are fundamental to go in to provide care. We absolutely need to focus on nursing leadership and the leadership of multi-professional teams going forward. We absolutely need to give greater emphasis to mental health because of the changing nature of society and how we see society changing, not just post-COVID and the psychological trauma, but our societal problems and the impact of patients and clients that we meet nowadays with bigger societal and psychological problems than I can remember when I was educated, requires us to change our thinking about the need for mental health in all programmes. We need to have greater emphasis on working across boundaries, and we need to be advocates in everything we do, not just about training. It's a word I really don't like, about training nurses, but how we educate nurses from a research focused and a research informed perspective. Finally, we also have to think from a systems perspective about how we make nursing and health as a viable career for many of our generations, not just young people, though the UCAS data does show higher increase of 18-year-olds coming into nursing and that changing population and demographic of age. But we need to think about how do we make health and nursing a viable, attractive career. We need to think about the interventions we have with schools and colleges and the education we need to provide to some of those teachers and careers guidance people around how we can help support them in understanding when they talk to pupils about the value of nursing as a really progressive career with lots of opportunities. But that needs a systems-wide approach to partnership working, and we need to think about our financing models to support students. One of the reasons I think we might be seeing a decline in the mature student market to nursing is around financial support. I hold nothing back on this. I've been a long advocate and continue to advocate with Department of Health and Department of Education around what I call forgivable loans, a term that's not liked by the politicians. but actually the ability that the longer you work within the NHS, the less money you pay back for your education loan, so that actually we use that to attract people in to the into the nursing workforce. It's not attractive because it's not a political winner, and I think we need to find creative ways, of which there might be others, in order to make that attractive. So in closing, I said at the beginning, is nursing an uphill struggle? Yeah, I think it is going to be an uphill struggle. And I acknowledge that we need the space to work through some of those issues, but we cannot face some of the data that we're seeing by some fantastic researchers and workforce analysts, such as Alison Leary from South Bank University in London, a professor of workforce modelling, who has a huge contribution to make in this space, colleagues in the Health Foundation, colleagues in the King's Fund. All indications are showing that the challenge ahead is huge, and that will need a different and radical solution. So, is it a struggle? Have we made that struggle ourselves? I don't think we helped ourselves in higher education when we saw the removal of the bursary and the introduction of fees. I fought long and hard with colleagues at the RCN, the RCM and UUK to bring back a maintenance grant, which we eventually got in. So students in England had that maintenance grant, different funding models in different parts of the UK, some that are actually much superior to what we're doing in England, such as in Scotland. And the Wales approach, I think, is really admirable in what they're doing and how they've addressed it. So we need to think about some of these solutions going forward. I'm not going to say much more this evening. I want to thank you for listening to me. I know from when I've spoken before, some of these issues can be controversial and they can be challenging. I finished my term of office as chair of the Council of Deans, and that's been a 6-year journey as chair, which has led to many, many conversations with ministers, politicians, etc. But one thing I am confident of, while I may finish as the chair of the Council of Deans, I will not finish being an advocate for the profession of nursing, the profession that I love. Thank you.